Hello, my name is Dr. Robert Gish. I'm working in collaboration with the liver group at Renown, and we're setting up a series of educational programs. I'm a professor consultant at Stanford University, and this collaborative is helping to move forward guidelines, protocols, and improving the standard of care at Renown for managing liver patients. We're going to talk about transferring patients between the floor and the ICU, when to transfer, when not to transfer, and really get you involved as a provider in this special process. Our target audience includes hospitalists, GI fellows, house staff, intensivists, gastroenterologists, hepatologists, liver surgeons, our nurse practitioner, PA, liver staff, and pharmacy. My disclosures is I want to maximize patient survival, decrease deaths due to end-stage liver disease, shorten hospital stays if possible, decrease readmissions and admissions to the hospital, decrease time in the ICU, and of course, move patients quickly to the ICU as indicated. This management team requires a multidisciplinary approach, and it also includes other subspecialists, radiology teams, as well as pathology. There's been a lot of famous quotes when we're talking between the hospitalist, gastroenterologist, and intensivist when having liver rounds. There seems to be some interesting and not fully understood ICU criteria. And then the patient has been stable. Well, if they've been stable for 1 hour, that really doesn't count. Stable for 6 hours is an incredibly short period of time of stability for a liver patient. And liver patients tend to crash really fast. They change very quickly. So the threshold to move to the ICU, in my opinion, should be much lower than another patient who may have a simple pneumonia or cellulitis or something else. These patients crash, they decline rapidly, they can die waiting on the floor for that ICU bed, or can become critically unstable and lead to a code on the floor when they're best managed in the ICU. Of course, trying to prevent that, but if the code occurs, it's better in the ICU setting. The shortage of ICU beds is really not a reason not to transfer a sick liver patient to the ICU. There needs to be coordination, collaboration, and dialogue to find the right bed for the right patient. Remember, an afebrile liver patient may be critically ill. That patient's temperature is 94, they're afebrile, but they're actually hypothermic, a sign of critical impending sepsis and decompensation, probably a sign of a severe systemic inflammatory response. Please round together, work together as a team. Very important to have this face-to-face dialogue, attending to attending dialogue. What about, I can't place a central line because the INR is too high. Well, it's not the INR that matters in a liver patient, it's the thromboelastography tracing. R value, K and angle, and of course the maximum amplitude indicating liver, and most importantly, platelet function. We talked about NG tube and varices in our other presentation about when to admit patients and bring the patient into the hospital. And remember, lactulose is not there to treat an ammonia level. You're there to use your encephalopathy treatment to treat the patient. Hysterexis, mental confusion. My recommendation, stop doing ammonia blood testing. Look at the patient, do a physical, do a neuro check. And finally, feeding tubes. Nutrition is terribly poor, terribly bad in our liver patients. These patients need tube feeds. You can actually have an obese sarcopenic patient. They cannot eat 6 to 8 times a day, which is what the cirrhotic diet is in 2015 and beyond. These patients need to have tube feeds. They need to have 2,000 to 3,000 calories per day. They need continuous feeding to give them a continuous glucose support. These patients are hypoglycemic, which results in gluconeogenesis in the muscles, decreasing muscle mass by metabolizing and digesting muscle to create glucose. We're going to move to liver transplantation just for a moment and talk about the ultimate treatment for liver failure patients is getting them a liver transplant. I work at Stanford University, and it's very important to be thinking about that transfer to a transplant center when deemed appropriate. You may already know that on your first evaluation of the patient. They're low risk for recidivism and alcohol and drug issues, good psychiatric, good family support, and don't have serious comorbidities that might indicate a short lifespan even with a liver transplant. Right now, there's only 6,000 liver transplants in the U.S. There's 60,000 patients who die of end-stage liver disease or liver failure in the U.S. each year. Our job is to try to save or extend the life of those other 54,000 patients who are not transplant candidates. Unfortunately, we've got problems with a flat deceased donor, few live donor liver transplants, and a huge number of patients who are on the liver transplant wait list. Every patient in the hospital, when you're thinking about transferring from the floor to the ICU, you need to have a current MELD score, recent MELD scores, and look at that MELD trajectory. The MELD score is designed to look at 3 and 12 month survival or mortality. Here is that mortality graph. We have strata less than 15 to look greater than 30. Look at the 2-month mortality shift. You've got a MELD score over 30. Those patients need to be transferred to a liver transplant center such as Stanford, or be considering hospice, or of course looking for something that short-term is easily reversible. Share 35 has changed things. Those patients, especially in the West Coast region, are not having low MELD scores. Everybody who's getting liver transplants tends to have MELD between 33 and 40. Some liver cancer patients are getting organs from high-risk donors. High MELD scores in acute liver failure patients are at the top of that list. Let's keep people alive together until they can make it to a transplant center and liver transplantation if they're listed. Let's talk about keeping those patients alive on the ward, moving them early to the ICU if they're changing, keeping them in the ICU until they're truly stable. Rapid movements from floor to ICU, back to floor, may not be in the best interest of that sick, complex patient. Acute liver failure can actually present in 2 ways. We have fulminant hepatic failure in somebody with no underlying liver disease, or acute liver failure superimposed on chronic liver disease. You make that difference, and there's different scoring systems in place, especially for acute on chronic, how to stage those patients, how to treat those patients. Look for multi-organ failure. Treat early with antibiotics. Look for sepsis with blood cultures, sputum cultures, early paracenteses before they're on antibiotics, getting cultures and blood culture bottles at the bedside. In those patients who are hypotensive, we'll talk about Hepatoadrenal Syndrome. On the ward, they may be adrenally insufficient. They may need Solu-Cortef. They're probably going to need to be in the ICU until that blood pressure is stabilized with low-dose pressors, adrenal support, treating their inflammatory syndrome, treating their infection. Let's break down barriers. Let's improve communication. Let's have face-to-face, attending-to-attending level discussions about moving patients from the ICU to the ward to the ICU. Think about infection in all of your patients. You really need to think about hepatorenal syndrome and managing those patients early, not with hemodialysis, but with CVVH. The rare liver patient who can tolerate hemodialysis needs to have a base blood pressure of greater than 100 to 110 and be maintaining greater than 100 to 110 while on hemodialysis. Decreased liver perfusion that you see with hemodialysis can further compromise dramatically liver function. ICU criteria needs to be different for each patient population. Think about that liver patient. There has been even a significant gradual change in renal function and blood pressure. Move them to the ICU so they can have rapid and early interventions for their different complications and disease state. Listen to your GI hepatology team. Integrated care has worked, in my experience, and markedly improved decreased waitlist mortality. Acute liver failure, We discussed the difference between fulminant liver failure and acute on chronic. You need to be monitoring bilirubin, the most sensitive and best liver function test. Change in INR, but supplement that daily with thromboelastography. Be monitoring closely for hepatic encephalopathy. Not ammonia testing, but a neurophysical exam. Patterns of presentation could be from hyperacute to acute to subacute. And we mentioned acute on chronic. Intracranial hypertension is the worst in the hyperacute and acute. Much more rare in subfulminant and acute on chronic. 2,000 to 3,000 cases a year of fulminant hepatic failure. Acute on chronic, we're probably estimating another 4,000 to 6,000 cases per year. Patients can die waiting for liver transplant. In the West region, region 5, it's about 1 in 5 to 1 in 4 patients. Let's talk just for a moment about acetaminophen overdose and liver toxicity. N-acetylcysteine, a critical support for those patients. This can be worsened, the acetaminophen toxicity can be worsened by alcohol or fasting. We want to feed these patients, tube feed these patients, IV N-acetylcysteine for at least 3 days. We're continuing the N-acetylcysteine in fulminant hepatic failure patients much longer after they've cleared acetaminophen blood levels. We're actually continuing this for 5 to 7 to 10 days until there's marked improvement in liver function, as measured by bilirubin and INR. NAC is the standard of care for acute liver failure from all causes, not just acetaminophen. The earlier we start NAC, of course, the better. Coagulopathy of acute liver failure, data is limited. What really needs to be enhanced now as an acute liver failure patient is TEG. TEG can markedly decrease this flooding that we usually give for acute liver failure patients when we're trying to treat the INR. Just think about this, 14 units of FFP on average in patients with acute liver failure. Just think of the volume in addition to the red cells that may be given, the fluids for antibiotics, fluid resuscitation. This can move a patient from being dry to wet with pulmonary edema, intubated. Use thromboelastography to guide your coagulation support. Don't treat the INR, treat the patient. This is a diagram of a thromboelastogram. There's a whole additional presentation we'll have on TEG, but this is the way to establish what's going on with clot formation. That's the vitamin K-dependent cofactors. The kinetics of clot formation, that's the alpha angle, also called the K. And fibrinolysis, well, let's start before fibrinolysis. That width, that MA, maximum amplitude, is your platelet function. And of course, as you fibrinolyze the patient, you're going to decrease platelet adhesion, you're going to decrease that clot formation. Use TEG in your chronic liver patients, acute on chronic, and fulminants to guide coagulation status, assessment, and finally coagulation support. Acute liver injury, severe liver injury, minor changes on thromboelastography. Because when the liver gets sick, you're impacting pro- and anticoagulation factors in parallel. So a patient could come in, encephalopathic, an INR of 9, but have a normal TEG. We treat the TEG. Patient's not bleeding, the TEG is normal or near normal. They do not need coagulation support. By taking this into account, you can decrease the number of patients moved from the floor to the ICU because you're going to have less volume overload and markedly less trolley, transfusion-associated lung injury. Use TEG data, use blood products sparingly, will decrease infections, decrease overall mortality, because we understand treating the hemoglobin is best advised when hemoglobin's in the 21 to 23 range, not in the old parameters where we are treating hemoglobins less than 27, treating hemoglobins less than 12 to 13. Keeping hematocrits in the 21 to 23 range is instead of in the 28 to 30 range is advised. Let's move to infection and acute liver failure. These patients are at increased risk for bacterial and fungal infections. There's no survival benefit with prophylactic antibiotics or selective gut decontamination, but the message here is use antibiotics early if you think sepsis is present. And there is a move to treating these patients with probiotics. This changes the biome, and rifaximin may also decrease infections in acute liver failure patients. Low threshold use rifaximin if there's hepatic encephalopathy. Patients not on prophylactic antibiotics, surveillance for infections, even more than once daily, meaning physical, clinical assessment and cultures would be indicated. Then the patient starting to show signs of hypertension, systemic inflammatory response, broad-based antibiotics such as Zosyn and Vanco is advised. Remember, these patients are developing renal insufficiency, and vancomycin can accumulate and worsen renal insufficiency. So you and the pharmacy should be partnered in this, checking Vanco levels daily in somebody who's got a moving creatinine or GFR. Cerebral edema in acute liver failure. You can elevate the head of the bed, intubate and sedate with propofol, especially if they hit grade 3 hepatic encephalopathy. There are hypothermia protocols that we're developing, and you can move them to hypernatremia. No data to support ammonia-lowering therapies, but we are going to treat their hepatic encephalopathy with low-dose lactulose, basically having 2 to 3 bowel movements a day. Rifaximin, and there may be adjuncts to this as well. Never use neomycin. My advice is do not consider intracranial pressure monitoring, although some centers keep this in their armamentarium. In acute liver failure, fulminant liver failure, therapeutic hypothermia can be used for intracranial hypertension as diagnosed by scans, EEG, physical examination, retinal and optic nerve examination. Good coma care is essential for good outcomes. Steroids do not work. Mannitol is recommended. Hypertonic sodium chloride recommended. Propofol instead of barbiturates. Hypothermia, we think, is effective. And L-ornithine phenylacetate, not yet available in the U.S. Every patient with acute liver failure, we're talking about fulminant liver failure to make sure we're clear, needs to have pH assessed by arterial blood gas, monitoring INR and creatinine, monitoring bilirubin, very, very important issues in these patients. Sensitivity and specificity is good. Specificity maintaining over 80% in both groups for predicting outcome, death, need for transplant. Every patient with acute liver failure, specifically fulminant liver failure, needs to have a phosphorus monitored at least daily. You want to maintain the serum phosphorus above 3 to 3.5, ideally around 3.7. This is best done with intravenous phosphorus, not oral, because you already have the patient on low-dose lactulose. Oral phosphorus is not absorbed, it acts as a cathartic, and then you're going to have all sorts of problems with skin care, bowel care, nursing care. IV phosphorus. I've had patients require up to 500 millimoles over 10 days. And we really want to treat with 30 millimoles every 4 to 6 hours early so these patients can regenerate their liver and not develop a hypophosphatemic cardiomyopathy. Transjugular liver biopsy, very useful in fulminant hepatic failure for prognosis and diagnosis. Now, if you know it's hepatitis B, surface antigen's positive, DNA is high, IgM core may be positive in acute disease or reactivated disease, probably don't need transjugular biopsy, but even then it may help. It may also help you decide if it's acute on chronic or fulminant. That changes the ability to get specific scores, high scores, such as status 1 for liver transplantation. Nutrition, nutrition, nutrition. Acute liver failure, alcoholic hepatitis. 2 examples where tubes need to be placed with continuous 24-hour tube feeding. And my recommendation is to supplement that with intralipids. Interlipids are full of nice things such as cholesterol and lysolecithin. It's important for cell wall maintenance and building. Vitamin A, D, magnesium, and zinc supplementation is advised. Sub-Q vitamin K. They need about 30 kcal per kilo when they're in the ICU. No one can eat that much. And let's feed them every hour, 24 hours a day to help with hepatic regeneration and decrease catabolism. NAC. IV best first for 3 days, and if you have an NG tube in place, the bioavailability is extremely high after 3 days. For acute liver failure due to acetaminophen, fulminant hepatic failure due to all cause, you can switch to oral or NG tube placed. More data on the NAC trial. The next few slides we're going to move through quickly, but it does improve survival in non-acetaminophen acute liver failure, NALF as they call it. This just describes 173 patients enrolled. It talks about outcomes. Survival, transplant-free survival, statistically significant across multiple different stages. Transplanted also in terms of percent who need transplant was decreased. That was statistically significant. NAC improved across a number of different ranges. This was statistically significant, also compared to placebo. Start NAC early. Look at the differences in transplant-free survival. NAC was well tolerated, recommended especially for early stage disease. They're grade 3 to grade 4, it may be too late. Oral NAC after 3 days of IV NAC can be considered. Other treatments I'm going to really highlight here: increase their sodium, keep the sodium in fulminant hepatic failure patients in the 130 to 140 range at a minimum, and think about pursuing therapeutic at 150 to 155. In chronic liver disease patients, think about transferring that patient from the floor to the ICU. The ICU may be a better place to get that sodium of 113 to 114 slowly back into the normal range. They're going to need continuous monitoring, especially if you're using a drug such as the Vaptans, B2 receptor agonists that decrease free water absorption. We do not want massive stool outputs with lactulose. This causes fluid shifts, dehydration, electrolyte abnormalities. The base is 1 to 2 bowel movements a day, add rifaximin or other supplementary compounds we can use as well. Let's fix the volume. Let's fix the low sodium. That markedly is going to improve that patient's overall status. Improved survival can take place. Recent MELD score is being modified. There's what's now called the sodium MELD score. This also helps predict short-term survival, how sick the patient is. Another graph about how incorporating sodium into the MELD score is going to improve assessment and prediction of patients' 90-day survival or mortality rate. More information on hyponatremia. You want that sodium greater than 127. Sodium 122 indicates the need for hospitalization, potentially in the ICU. Under 118 to 120, ICU management is probably best unless you are convinced it's chronic. Complete an adrenal, thyroid, and SI-ADH workup on those patients. More information on hyponatremia management. 3% sodium chloride with Lasix is also an excellent adjunct to slowly improve that sodium so you do not develop in your patient central pontine myelinolysis. Paracenteses need to be done in the ward or in the ICU in a controlled setting with ultrasound on anybody who is unstable. First step is to look for infection. The second step is to look for possible bleeding into the abdomen. If you have a hypotensive patient 2, 3, 5 hours after a paracentesis, they're bleeding into their abdomen until proven otherwise. Simple test, 25 gauge needle under ultrasound guidance into the peritoneal cavity to look for blood and get a hematocrit. It can be done easily, safely at the bedside with a portable ultrasound device. Grade 3 hepatic encephalopathy, white count has gone from 4,000 to 8,000. Patient is infected until proven otherwise. Another slide that talks about the rate of SBP in hospitalized cirrhotics, the need for repeat paracentesis, even if the first one was negative, if the patient is changing their clinical status. SBP has a terrible 1-year survival rate. Refer those patients for liver transplant if they're a candidate. And of course, secondary prophylaxis is needed if the protein in the ascites is under 1 to 1.5. Treating acute infection, you're going to be using third-generation cephalosporins, Zosyn, Zosinbanco, or equivalent antibiotics. Anybody with GI bleeding needs to have antibiotics to prevent primary infection as well as secondary SBP. Got an ICU patient, blood pressure 70/40, dual pressors, triple antibiotics, culture's negative. What are you thinking? Hepatoadrenal Syndrome. Part of liver failure and septic shock with hyperdynamic and hypotensive circulatory stage. Several studies showed relative adrenal insufficiency, and there's no risk to a trial of 3 days of soluble 60 milligrams Q6 to Q8 hours. This can definitely contribute to circulatory dysfunction seen in hepatoadrenal syndrome. You can do baseline cortisol, random cortisol, or Porterson stim test, or better yet, borderline cortisol levels, or unstable patient, 3-day trial of soluble does not increase the risk of infection. In summary, we're developing a specialty hospitalist service here at Renown. Early admission to the ICU, attending discussions. There should not be barriers to ICU access. Make sure that ICU discharge or transfer out, that patient is very stable. Multi-organ failure has resolved. The ward is a difficult place to manage these unstable patients. Use thromboelastography. Consider hepatoadrenal syndrome. Supplement phosphorus for any deficiency. NG, continuous supplementation of nutrition, is strongly advised with the addition of intralipids. IV NAP for all fulminant hepatic failure, consider for acute and chronic. I'd like to thank you for your involvement with our liver program in developing this inpatient liver service and the excellent interactions we're expecting between the intensivist, the hospitalist, gastroenterologist, hepatologist, and the support of our pharmacy, nursing, ER, interventional radiology, our physician extenders, our transfer centers, all are key parts of this patient management. Thank you.